Yes, that's great.
Well, thank you very much for asking me to join this 2-hour webinar. And it's a great honour to talk about Peter Morris. I've never actually done, actually, no, I have done it once before. It was many, many years ago. And so it's been great fun going through some old pictures and putting this presentation together. This is definitely my most favourite picture of Peter. It's Peter when he was the president of the College of Surgeons in London. At this stage in life, he was pretty pleased with what he had achieved, I suspect. He had a great smile on his face and he was looking pretty relaxed. Sometimes when you saw him in the transplant centre, he was not quite as relaxed as that. And I had the feeling that, that he was a happy man at that point in time. I'm going to start this talk by presenting this picture of the first successful clinical kidney transplant surgery, which we've already seen. You can see Joseph Murray in the middle there, placing a kidney into a recipient. And I guess if there's a take-home message from my presentation tonight, it is that when it comes to kidney transplantation, the surgery is the easy part. The rest is difficult. The first transplant involved a couple of identical twins, Richard and Ronald. Richard was the recipient and Ronald was the donor. They had skin grafts beforehand and fingerprinting to confirm the fact that they were identical. And it was all pretty good, happy ending with this particular procedure. The recipient married his nurse and the donor died 52 years later, albeit with some poor kidney function. Now, if you look at this picture, and it definitely has a place in history, on the left side there of those 5 people, you can see their smiles, they're happy. And as you move over to the right, to the dark side, as I put it, you can see the live donor and the live donor surgeon. And my understanding is the live donor surgeon had a really difficult time with the operation. And this picture was taken about 6 weeks after the procedure. And you can see even then that the donor, the man with the triangle sign of stress, as my psychology friends tell me, is still worried about the procedure. He's probably got a large incision to the left side. So this was a great start and it made clinical transplantation possible, but it came with its problems. In 1956, Peter Morris, 2 years after this procedure was being performed, was a medical student at Melbourne University, and he subsequently described this as some of the best years of his life. But it was in 1956 that Maurice Ewing performed the first deceased donor kidney transplant in Australia at Royal Melbourne Hospital. And always the emphasis in transplantation in Australia has been deceased donation and not living donation. In his final year, he met Joss, who he married 3 years later, and they remained married. This is the intervarsity cricket match between the Melbourne University 11 and the Adelaide University 11, and it was played in Melbourne. It was a happy day. Even the umpires are smiling, and you can certainly cannot see any of those triangles of stress in the gentleman's fingers or hands in this picture. In 1961, after 3 years of medical officer experience in Melbourne, Peter and Joss headed to London, as Peter put it, for cutting experience and to pass the FRCS exam, which in those days there was no Australian surgical exam. The decision to go there was in part influenced by Dr. Claude Welsh, a visiting MGH surgeon from Boston, who Peter was most impressed with because he was pretty slick at the operating table, but most importantly, he always said please and thank you at the operating table, whenever talking to his nurses or support surgical team. He went to the Hammersmith Hospital and described what he felt for the first time he was in a truly academic surgical centre. Claude Welsh later went on to help Peter to open doors, as he put it, in the USA, initially as a surgical fellow in Boston. In Boston, Peter was blessed with a huge surgical workload as a resident, but he went there so that he could do research. And after his first year, he had no trouble finding some research positions, initially in looking at the mechanisms of infection defense. He then developed, because the lab was across the corridor from him, an interest in transplant histocompatibility with a very famous US transplant surgeon, Paul Russell. Towards the end of 1966, and before he really had much experience with histocompatibility, he was invited to return back to Melbourne by Professor Maurice Ewing, the man who'd done the deceased kidney donor transplant 10 years earlier, to set up and develop a tissue matching service at Royal Melbourne Hospital. Fortunately or unfortunately, they had inadequate funding after they appointed Peter to Royal Melbourne Hospital. This meant that Peter had to find some other research activities, and he was invited to join Dr. David Hume in Virginia. Dr. Hume was one of the initial kidney transplant team in Boston in 1954. And by this time in 1966, he had developed the largest kidney transplant centre in the world and was widely considered to be a superb teacher and who also enjoyed life to its fullest. Peter Morris was invited to analyse Hume's transplant sera, which was essentially a biobank kept at 120 degrees of all the pre and post-transplant buds of Hume's entire kidney transplant experience in Virginia. With this sera, he was able to demonstrate the development of cytotoxic antibodies and subsequently also described hyperacute rejection. 1968, I found the funding in Melbourne, and Peter returned to Royal Melbourne Hospital, where he was a senior lecturer along with some really good young surgeons in Australia, Vernon Marshall and Geoffrey Collins, who are famous for the Marshall solution and the Collins solution. They were impressive lecturers and tutorials, and as a medical student, and this is where I spent most of my time between 1968 and 1973. It was in the medical school at Royal Melbourne Hospital. I didn't take much notice of this, but a bit like Peter, I preferred to play cricket and football and do all sorts of other things apart from medicine during medical school. It was at the Royal Melbourne, however, where Peter developed a long working relationship with Alan Ting, a famous tissue typist. Peter moved to Oxford in 1974, where he was appointed at the age of 39 to the Nuffield Chair of Surgery, and with that came head of the whole of the Department of Surgery. He moved with his family of 5 children and was soon joined by his laboratory team from Melbourne, which included tissue typists and clinicians. The Kidney Transplant Centre opened in 1978. You can see a picture here of Peter with Professor Peter Medawar, physician, I'll go back one slide, physician Des Oliver, who's a little bit disinterested in transplantation, I suspect. And there's Peter. And this gentleman here is probably the closest one. He was one of the senior academics at the university and in the UK. And I think he had a small triangle of stress associated with opening a new transplant centre. I joined the Oxford team in 1984, and Oxford was a place that many Australians went to. And I put some circles there. The first one is, and the important people sat in the front row, and this circle here surrounds all the important ladies or women in Peter's life at Oxford at the time. For his secretary, Joan, the charge sisters of the wards that he worked in, and his senior research people in Catherine Wood, Sue Fugel, and Maggie Dolman. Maggie Dolman was famous for turning up to late for everything, so she was in the third row. The surgeon said here, that's me with very, very cold hands, because it was very autumnal when this picture was taken. And there's Jeremy Chapman. He was really the only physician in the whole of this department in 1985. And he didn't really have a clinical position. He was undertaking research in Alan Ting's lab, which is there. And the other important person there was the finance person. There are a long list of Australian trainees in Oxford. And the first was John Thompson, who returned to Sydney and became a very important liver and kidney transplanter, and now has a huge melanoma organisation set up here. Those of the early ones, we tended to work with people who also worked in Oxford. And for me, the important thing was was Jeremy Chapman. In 1985, you can see a picture here of Peter operating. If Peter were listening, I'd apologise for the black and white picture, because it looks a bit like the old Boston picture. But Peter did all of the living-related kidney transplant procedures. They're invariably done on Monday mornings in a dedicated operating theatre, but we also had a dedicated biochemistry laboratory. The urologist performed the nephrectomy, and Peter did the recipients. The role of the surgical fellows was to do all the deceased donor retrievals and the recipient surgery. Peter Morris determined the immunosuppression protocols, and they're usually all within Oxford clinical trials. The other important event that happened for me in 1985 was to see the sixth and last pancreas transplant performed in Oxford using the duct occlusion technique, example of which you can see here. I enjoyed life in Oxford, particularly playing in the Oxfordshire League cricket. And this is a picture that actually was taken at Peter Morris's festschrift in 2001 at Blenheim Palace. I could never find Peter on Saturday mornings, because he was always playing golf and didn't have a mobile phone. And he could never find me on Saturday afternoons, because I was always playing cricket. There was always a good side and a soft side to Oxford. In 1985, Peter approached me and said that I'd played enough cricket in Oxford and it was time for me to go find another job, and that I'd better improve my CV, and that there was the potential that I could be invited to start up a new transplant unit in Sydney at Westmead Hospital. With a weather like this at John Radcliffe Hospital, there was no reason to want to stay in Oxford. And like all Australians, we'd all tend to go back home. The most important person I brought back from Oxford was not a tissue typist, but he was, I suppose, in some respects, which was Jeremy Chapman, who had developed a very important working relationship within the unit from a research perspective and from a clinical perspective. The man here who looks a little bit disinterested is a pancreas transplant surgeon at Westmead Hospital, who had done a lot of research, but all using duct occlusion models. And when we started up the program in 1987, we used a whole pancreas technique. We started up a prospective assessment of all the benefits of simultaneous pancreas kidney transplantation, and it's really formed the basis of Westmead's reputation in clinical transplantation. In 1990, we put up our first graph at an international meeting, and this was a 100% graft survival out to 30 months for the first 10 patients that we'd operated on, all with great blood glucose levels and serum creatinines. We set up a research team, transplant research team, and to a large extent it was a bit like Peter's model back in Oxford. There was the transplant fellow, and Howard will recognise his picture, and I think that's from 1990. And Wayne Hawthorne, who started off as an animal health technician but ended up being a professor of transplantation. surgery at Westmead Hospital. And he's one of the world's leading experts in xenotransplantation using islets. I can't remember who this lady says, hi folks, remember me. Now, kidney transplant surgery, I think, is easy, but there's a big difference between the donor sources. And Peter Morris was really very keen on the use of deceased donors. And when there was a living donor on a Monday morning in Oxford, he was a bit more tense than usual, and that he always came in on Sunday night to see the recipient and the donor to make sure everything was right. It was the advantage of elective surgery, known recipient, known anatomy, optimum donor condition, and always the senior surgeon. And compare that to the deceased donor situation where it's emergency, waiting list recipient, unknown donor kidney. The kidney could be good, bad, or ugly in condition, and it was dependent on an on-call surgeon. And it's no different anywhere else in the world to this day. Now, the living donor procedure is one that Professor Modi will be talking about later in this program, and Howard Lau might mention as well. And I watched my donor nephrectomy colleagues and Howard for many, many years doing these procedures. And it's not an easy operation. I suspect they don't sleep all that well the night before, nor the night after, because they're doing an operation on someone who will not benefit from the operation at all. And I've put up an example here of the sorts of issues that exist. And there's a kidney with 3 arteries that the 2 upper and lower pole arteries are easy to handle, but what do you do about the main renal artery? And there continues to be a lot of discussion how best to treat that donor renal artery. You can imagine if that hemalock or metal clip should come off, it would be a disaster. And most of the mortality and morbidity associated with the live donor procedure done laparoscopically relates to this artery. Also, living donation, Peter always considered it a procedure of necessity. It was an abrogation of the responsibility in many areas of the world to develop a deceased donor program, particularly if hearts, lungs, and livers were required. No benefit to the live donor, real risk of living donor death, 0.3% risk of kidney failure after 15 years in the best of circumstances, coercion by family members and others, commercial opportunities, and transplant tourism. And Peter transplanted a number of patients from Oman, and I could see that he was sometimes concerned about the donors and where they came from, and there was always wide discussion, and eventually we would say yes, it was inappropriate to undertake an altruistic live donor procedure. Now, we all have experienced or come across patients who have bought their kidneys. And this was one of my patients a few years back whose first post-operative assessment after transplant surgery was in Sydney, with the procedure having been performed 6 weeks earlier in China. And you can see the size of the diamond on her ring. So her family had no problems in paying for her 120,000 Australian dollars, which is about 80 or 90 thousand US dollars for her procedure. She'd been a patient I'd known for many years because she was a dialysis patient, and she'd not been offered a kidney transplant in 8 years. So for her, from her perspective, life was not going in the right direction unless she had a live donor kidney transplant. Now, in Australia, we had a pretty poor deceased organ donor rate, and you can't really get on top of paid organ donation or reduced living donation unless you have an effective deceased donor program. And hopefully Sunil Shroff will talk about this later in the program tonight. The green line represents the live donors in Australia to 217, and it went down again in 2018 and 2019. And our deceased donor kidney numbers continue to increase and show no sign of decreasing. If you look at the sources of the living donors in Australia, This is 2009 when we put a lot of resources into promoting deceased organ donation and a few resources into paired kidney exchange. And we put a lot of resources into that, and they now make up about 20% of our live donors. And these are people who are usually having the procedure because they are highly sensitized. And our living donor numbers continue to decrease, which is a good sign. Now, I've got the last two slides that are about what I think the biggest contributions that I think Peter's made to kidney transplantation around the world. His research record is extraordinary, with many more than 800 papers and at least 16 books that he's written or written chapters in. This is kidney graft loss in the first 6 months after transplantation in Australia. And I've compared two eras, and I've not updated it because it really hasn't changed in terms of causes of graft loss. The green here represents 1970 to 74. This is when Peter Morris first came back to Australia, before he put a lot of, before he and many others developed a greater understanding of the histocompatibility, and before immunosuppression became much more sophisticated with the use of cyclosporin and tacrolimus. So rejection rates dropped. Graft loss as a result of rejection in the first 6 months dropped dramatically over that period of time. The technical losses as a result of surgery has improved a little bit. But as you can see, in this era, 2005, 9 and today, the major cause of graft loss in the first 6 months after transplantation is surgical. And I think we can put this down to development of a multidisciplinary team, a research team, all these things that Peter taught me in Oxford and has taught other people around the world. The other is that when you get presented with a deceased donor kidney, you might know what's inside that plastic bag when you open it up, but you're pretty confident, you can be pretty confident in this era that there will not be a hyperacute rejection will take place on the operating table. Finally, some personal notes about Peter. I think he's just the most fabulous man. And if you went to Oxford and you worked in Oxford, you felt like you were part of his big Oxford family. He has a very strong family life of his own, but everybody has been there, seems to know Peter well, and he knows you. It's amazing how many people he knows their names of, and he can even tell you what their children are up to. Quite an extraordinary man. I'd like to acknowledge Peter Morris himself, and a lot of the information I've got has come from his Medawa Prize acceptance speech, which was published in Transplantation in 2006, and acknowledgements for discussions that I had in the last week or so with Jeremy Chapman, Catherine Wood, and a lot of help from Dr. Google with the pictures. Thanks very much, Kim.